All right, good morning. I'm gonna have another chat about two different syndromes. Both of them actually, both of these have been known for quite a long time, but the connection between the mast cells and the connective tissue that the mast cells operate in has only been recently appreciated, probably within the past few years. So I'm going to give you my brief introduction on how I had to re-educate myself about connective tissue disorders a few years ago, since I'm an allergy immunology specialist. And I know most of you have heard quite a bit about this, but Dr. Ehlers and Dr. Danlos described this quite a long time ago. This is actually a gentleman, Mr. Abrams from P.T. Barnum's circus back in the 1800s, who was quite elastic. And we know that there's quite a few spectrums regarding individuals that have connective tissue disorders. Some of the genetic basis we understand regarding that would lead somebody to have a connective tissue disorder, some we don't. And actually, what I find to be very interesting is that the hypermobile type, as well as the spectrum connective tissue disorders, we still are trying to appreciate what the mechanical basis of developing these connective tissue syndromes is about. And as an allergy immunology specialist, I'm going to just throw my hat into the thought ring in that there may be something coming from the mast cells that's causing a diffuse connective tissue disorder. So the connective tissue, as been presented quite a bit through this weekend, really is composed of lots of different substances that essentially is the brick and mortar of our bodies. And there are several factors that can influence the dynamic structure of the connective tissue. So it's what you inherited from your parents and ancestors, the things in the environment that will impact the connective tissue, and that will also recruit an immune function. And if you have immune dysregulation, you can actually cause changes in the connective tissue itself. We see this quite a bit in asthma, where ongoing inflammation can actually cause scarring of the lungs, which is essentially called fibrosis. So there are, as you know, quite a few subtypes, and this is an old slide, so pardon me. But what I want to point out is sometimes you have to learn as a practitioner and as a patient, you might not necessarily have a lab test that supports your diagnosis. And that's definitely the case in hypermobile type Ehlers-Danlos syndrome. So for years, the focus for patients that had connective tissue disorders was mostly orthopedic. So it's either the neurosurgery, orthopedics, and rheumatology. They're the ones you would hope to be most knowledgeable, but I appreciate the comments by Dr. Rodney Graham on how the community that has hypermobile syndromes are really underserved by the practitioners that are in those specialties. So the question I pose to you is, why is an allergy immunology specialist standing in front of you today talking about a connective tissue disorder? And I would have to go back to a young man who I met 10 years ago, who kind of opened my eyes beyond the one board question that I had 20 years ago. But in the past 10 years, I would say I was getting an increasing number of referrals from specialists, neurology, cardiology, neurosurgery, because they were seeing patients that had connective tissue issues as well as dysautonomia, and they were having allergic-like or hypersensitivity reactions. And so they would send them for an allergy immunology evaluation, and about 95% of these patients would go get tested. They couldn't find IgE to pollen or food or medications, and unfortunately, they were basically said, it's not allergies, good luck, God bless you. So I want to introduce you to Sean. This is a letter that his mother wrote to me when we were trying to get a grant to try to better understand what is going on in individuals that have hypermobile disorders. And by the time I met him, I was allergy immunology specialist number 11. And he had already seen close to 20 specialists by the time he was 4 years old to try to understand why he was flushing, why he didn't tolerate foods, why he had episodes of anaphylaxis. And of course, the allergy testing over and over and over again was completely negative. And basically, they said he would outgrow it, but it's kind of hard to give a prognosis if you don't know why it's happening. So from the allergy immunology perspective, we know that there are lots of different ways to activate mast cells in the connective tissue. So you have the allergic, where you're finding an antibody called immunoglobulin E, or IgE, that recognizes pollen or mold or animal dander, and even occupational materials as well. You can also develop an antibody against your own mast cells. So you actually end up with one part of the immune system attacking the other part of the immune system, and that's called autoimmune urticaria. But as you can see here, there are hosts of other clinical entities that can also cause mast cells to uptick. And for me, it seemed a pretty straightforward observation. If these cells are responsible for acting as the first line of defense below the surface area of your connective tissue, in adults, you're talking about 75 square feet of territory that needs to be guarded every second of every minute of every hour of every day. So they have to have various sensors to try to figure out what's dangerous and what's not. This is an old slide showing that there are lots of different receptors on mast cells that recognize bacteria and parasites and viruses, naturally occurring toxins such as those that might be injected by a mosquito or a poisonous frog, whoever you might be encountering. What I find most interesting, there was an article in the New York Times just a few weeks ago talking about meat allergy. And what's really interesting is this is a observation where an infection causes a chronic allergy to develop. So you need to kind of understand that there's some type of dysregulation going on in the immune compartment that may be impacting how the connective tissue functions as well. So after I met Sean, I did what probably most of you do, and I checked Dr. Google to try to figure out what is the connection between connective tissue and hypersensitivity reactions that allergy testing wasn't addressing. And I came across this gentleman named Dr. Symes, and he started describing his patients who would end up with ruptures of their ligaments, especially in the spring and summertime. And I actually witnessed that because this happened to a family member on my brother's side. And he tried to see whether or not there was some type of an association between kind of like seasonal allergies, or another way to say allergies is allergen IgE triggered mast cell activation, but it's just easier to say allergies. And he speculated that there might be something going on in the immune compartment that might be impacting the collagen and causing a connective tissue issue. Dr. Symes is a veterinarian, and he identified that there were certain breeds that were much more susceptible to having hypersensitivity reactions. So Bijons, the family member in my household was actually Harley, who was an old English bulldog, who ended up having, she had to have a special diet. Her skin had to be taken care of because she's very sensitive. This dog had more spa sessions than I did. But the same thing for the King Charles. But what's really interesting is now we have a model for the conversation that's going on in the tissue between the connective tissue and the mast cells. So doing a little bit more research, I came across this article, and this is one of the earlier articles that I saw commenting on what happens in individuals that have Marfan-like features back in 1977. And these individuals that had Marfan-like features were much more likely to develop an allergic or atopic disorder compared to individuals that had different forms of connective tissue disorders as well. Fast forwarding to the 21st century, this is work done by Dr. Joshua Milner, and I really would like to emphasize that we really don't know what a normal tryptase is. So he's been able to identify, and there's a company here, Gene by Gene, that can offer help in trying to diagnose individuals that have mast cell disorders. But what he found, and this is an article in Mental Floss, this is a young lady who actually has Ehlers-Danlos syndrome, dysautonomia, and mast cell activation syndrome. And what she describes is just a daily struggle just to do normal activities like get up, go to the bathroom, take a shower without fainting. And this is the first observation where an enzyme tryptase that's only found in mast cells can cause these 3 comorbid illnesses. So as Dr. Maitland had just mentioned, who's zooming who, what's the chicken and what's the egg, it's very possible that there are genes that are intrinsic to the connective tissue that can impact mast cell function. But now it seems that there might be enzymes that are or chemicals that are solely found in mast cells that can impact the function and structure of the connective tissue. This is the article that was published in Nature Genetics back in 2016. And essentially, if you have and I believe now the level is an 8, if you have 8 or higher in your serum tryptase, it would be worthwhile for you to get this genetic test to see whether or not you have a duplication or triplication of the tryptase gene. Dr. Mark Hastori, back in 2012, commented on there's lots of things going on in individuals that have connective tissue disorders besides rheumatological issues. And he speculated about immune dysregulation, but there really wasn't any particulars on what cells or proteins from the immune system, whether the innate immune system, which you can find in lots of different organisms, of which mast cells are part of, or the adaptive immune system, which are antibodies and T cells. And I think it's important to understand that you should know that most practitioners are well educated, somewhat educated on T cells and B cells, which is what all of us have been taught in medical school, the 5 lectures that we got 20 years ago. But as far as mast cells, very little is taught about this cell population, so there's a lot of ignorance among the biomedical community. It's getting better, but we still have a long ways to go. So I decided to after meeting Sean, I decided to do a little study. It was a retrospective analysis of 10 patients. There were 3 families and 2 separate individuals, and you can see that this young lady is quite bendy. But also, she was allergy tested, and her reactions were much more pronounced compared to a child that I had tested beforehand. So there seems to be other factors that can influence mast cell degranulation, in addition to just having an allergen, meaning you've made an antibody against a substance that's foreign to you. Oops. So we simply just sent some questionnaires to the 10 patients and asked them, do you get nasal congestion, postnasal drip? Have you had hives? Are you feeling itchy? And most of them reported that they were having those symptoms. We also asked, do you have asthma, or have you been given the diagnosis in asthma? And yes, that was also the case. Most of them had been as well. And interestingly enough, it's been generally thought that anaphylaxis is a rare event. But a study only a few years ago shows that at least 1 out of 50 of us have had an anaphylactic event. And please understand, anaphylaxis is kind of like earthquakes. You can have a 1.2 or 5.6. So if you have throat involvement and gastrointestinal distress, but it's very mild, which you can treat with antihistamines, that is considered anaphylaxis. So the lab studies, which was really interesting, is all of these patients had no detectable allergies to airbornes or foods. Their tryptase was less than 10. However, they were still symptomatic. This is just some of the data to kind of illustrate the fact that they all had rhinitis or asthma and they're itching, but the lab data did not support what we were diagnosing. And I try really hard not to put my lab testing ahead of the patient's story. So essentially, the diagnosis of mast cell activation syndrome is on this clipboard. It's like, do you have signs or symptoms causing irritation in at least 2 or more organ systems, meaning are you itchy and having gastrointestinal distress? Are you having a headache disorder and having itch in your throat if you eat fresh melons or bananas or apples? Do you have asthma and interstitial cystitis? All of these are worrisome for having an immediate hypersensitivity disorder that may be due to allergies or other triggers that are not considered allergies. But interestingly enough, I'm going to call this mast cell-ish because none of the data that we had at the time supported that these mast cells were dysregulated. But the lucky thing about this is that most of the therapeutics that we use to help individuals try to feel better have a really good safety profile. So it's not unreasonable to try medications that either target the mast cells or target mediators that are released by the mast cells to see whether or not it improves your symptoms or not. Unfortunately, the term regarding how practitioners should approach patients is we have a tendency to kind of put the test results ahead of your story. And unfortunately, if we can't measure it, it doesn't exist. So it's not unusual for patients that have mast cell activation syndrome, Ehlers-Danlos syndrome, or dysautonomia to have delayed diagnoses. And in addition to feeling unwell, and I believe there's been some wonderful lectures this weekend, that a lot of individuals end up with post-traumatic stress disorder, not from their illness, but from the practitioners who tell them it's all in their head. And by the way, this comment in the purple box, this was Francis Peabody, who was considered one of the original top docs back in the 1920s. And he also was concerned about how doctors then were putting test results ahead of patient stories. And I'm like, well, what did you have back in 1927 that you can be so arrogant about knowing all that's going on in a patient's body? And you have to understand, this is not a question about the test results. This is the operator. This is the practitioner who's interpreting the results. So it's really important to understand that the original term from Lord Kelvin was, if you can't measure it, you can't change it. And this is, I'm hoping that gives you some tools to kind of change the conversation that you're having with the practitioner who's trying to help you feel better. So, MCASH-ish. Few or no allergies, but still reacting. Everybody thinks mast cells are the bad cop. You know, honestly, these are just honest cells, honest men and women who are trying to protect us from dangers. And so it's just a question of situational. And I believe that, you know, every once in a while we'll have a bad apple, a police officer that might go rogue. But for the most part, you know, men and women that are trying to protect us are really trying to do their job, and they're following the laws on the books. It's just a question, we need to figure out what those laws are when it comes to your mast cells, trying to help you negotiate your next steps. So this is a wonderful comment from a German philosopher who basically says what our immune systems are doing. And basically, we have embodied, inherited responses to injury, to recognize and respond to injury. And what has happened with industrialization is that we have so dramatically changed our environment. And all of us have a tendency to focus on what we have a lot of control on, meaning what we eat. But here's the thing, and this is a comment I had spoken with some people yesterday. You maybe eat 3 or 4 times a day. You might drink a little bit more than that. You breathe 18 times per minute, and your skin is constantly exposed to the environment. So your body has to figure out what should stay and what should be kept out. And the cell population that is at the forefront of this is the mast cell. And the reason why it's kind of hard to diagnose an individual with mast cell activation syndrome, this is not a blood issue. This is a tissue issue. And one of the analogies I use is like a city that has a wall around it. Not very effective with really, you know, strong adversaries. So you're going to need some help. And this is a picture of the Great Wall of China, and it was manned by guards intermittently. And that's the same thing that what mast cells are doing. They are individual border patrol all along your skin, your gut, your respiratory tract, your urogenital tract. And if there's a site of danger, location, 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 you're going to increase the presence if there's something going on and help is needed to try to contain a perceived danger. So I'm just going to quickly talk about mast cell orders or mast cell activation. There are a plethora of receptors, if I do this right, on the mast cell to recognize viruses, parasites, toxins. But also, ladies, they have estrogen and progesterone receptors, so this can definitely influence the function of the mast cell, which can then impact how your connective tissue works. We see this, actually I just saw this in a patient recently. She developed joint laxity by the second trimester, so she was wearing braces on both her wrists. And then she got a tick bite, and now 9 months after the pregnancy, she's unable to pick up her child. She has bilateral neuropathy in both of her arms and joint laxity that's just recalcitrant to any therapies that have been offered at this time. So mast cells are born in the bone marrow, and that's where they get their initial training saying that you're going to be a mast cell. And then they get shipped out. Mast cells are a very heterogeneous cell population, and you can understand they are trained to serve and protect the community of cells that they've been assigned to. And I was mentioning yesterday, very similar to a man or woman who joins a police academy. They get their initial training, and then they get assigned a community of cells or a community. The analogy I used is, this is not political, but if you could think of a police officer who's assigned to Trump Tower as opposed to, Scarsdale, New York, there are different needs in those communities. That police officer has to learn how to recognize dangers in those particular communities and respond with appropriate force to contain any dangers. And also learn how to be tolerant to things when it's not a dangerous situation, but is different from what they've seen before. So with mast cells, they are solitary cells. Mast cells at rest are circular. They don't upregulate activation markers. And honestly, kind of like the police officer, they have chemicals that can contain viruses and bacteria. They have the ability to call in the SWAT team called eosinophils to kill parasites. So you don't want those chemicals being released willy-nilly. So if a police officer sees somebody down, you want them to call an ambulance, not the SWAT team. If they see a fire, you want them to call in the fire department. Same thing with the mast cells, depending on what they see. If they see bacteria, they're going to call in neutrophils. If they see parasites, they're going to call in eosinophils. And there's some things that they can handle on their own, like an insect bite. And one way you can really identify somebody who has a connective tissue issue and mast cell activation is they have large local reactions to mosquito bites. Or they'll anaphylax to yellow jackets and honeybees, and you won't be able to find IgE to those stinging insects. So again, it depends on what code is being sent out. We'll recruit in what population if needed per the judgment of the mast cell after its surface receptors have been engaged. Mast cells are part of the innate immune system, which means I can find mast cells in Drosophila, but I can't find antibodies. So you can understand, and this is just to reiterate, that these mast cells can be activated by lots of different things besides IgE, or immunoglobulin E, that recognizes peanuts or mold. They basically act as border patrol to keep out bacteria, viruses, and toxins, again, on your skin, your gut, your respiratory tract. And if they make the wrong call, meaning they don't react to things that are dangerous, that means you may have an immune deficiency. And what does that look like? Recurrent sinus infections. So again, we're talking about border patrol. It's really important to understand that mast cells, even though they see a mugshot, they see a virus, they will not go after it unless there's some type of tissue damage to recruit it. So mast cell activation disorders are described as having recurrent symptoms, and you respond to medications that target the mast cells. And lastly, what data do you have to support whether or not your mast cells are overactive or not? And I have to tell you, this is kind of the sticking criteria that's kind of hard to fulfill, and I'll get into it in 1 minute. So what symptoms do you have that are worrisome that your mast cells are misbehaving? How well do you respond to medications that target mast cells? That includes Claritin, Allegra, Benadryl, Zantac, Pepcid. And then what test results do you have to support that your mast cells are overactive? Everybody has a tendency to focus on histamine. I use this slide to show that histamine can impact at least 4 different receptors. Benadryl and Zyrtec goes after the first receptor. Pepcid and Zantac goes after the second receptor. An old-fashioned medicine used for depression, Elavil, nortriptyline, doxepin, goes after all 3. So what's really interesting is, as an allergy immunology specialist, I use this to help treat hives. Gastroenterology uses it for IBS, and neurologists use it for migraines. And interestingly enough, it was first designed to help mood disorders. So you can understand there's a lot of relationships between mast cells and different comorbid illnesses. This is just to give you an idea with individuals that have clonal mast cell disorders. Typically, you'll have itch or gastrointestinal distress, but the third most common is neuropsychiatric. The same thing for individuals that don't have a clonal mast cell disorder. This study was actually Allergy, immunology, partnering up with gastroenterology, and you can see again, skin, gut, and then the brain. This is again to give you an idea of all the different types of signs or symptoms that might cause individuals to have or might be worrisome for individuals that have mast cell activation issues. Again, recognition is the first thing, and then to try to go after the testing. Testing, so the marker that's the most sensitive and specific for mast cell activation syndrome is tryptase. The histamine, the prostaglandins are suggestive because they can be made by other cells, including mast cells. Basophils make them as well. And I'm using this to kind of illustrate the fact that mast cells elucidate lots of different chemicals. These chemicals are also made by other cell populations, but they have the ability to impact lots of different types of organ systems. So you can see that you may have brain fog, mood disorders, sleep disorders, IBS, not well-controlled congestion in your upper airways, failure to thrive, and fatigue. And a lot of this might be because the mast cells are being recruited. It's just a question of, is this the mast cell starting it, or is the mast cell being called in by another situation? And lastly, these are the various medications that are available. The medication I have a tendency to use most often if I don't identify another disorder like an immune deficiency or an autoimmune disorder is a medication called Xolair that is the anti-IgE molecule. We also are using traditional Chinese herbal therapy, acupuncture and acupressure, histamine blockers, the tricyclic agents, and oral steroids work on mast cells, but you really don't want to use this medication on a long-term basis. When you're looking for mast cells, again, this is a tissue issue. If you've had an endoscopy within the past 3 years or a colonoscopy or skin biopsy, and the tissue is typically held onto for 3 years, you can go back and restain to see whether or not your mast cells are misbehaving or not. And again, depending on what's tickling the mast cells will decide what chemicals are kicked out, which then would influence what kind of symptoms and signs that you might be experiencing. This is just to briefly understand that on average, it takes years for individuals to get a mast cell diagnosis. A lot of it is because it's just not taught very well on either side of the pond. It's just that there are very few allergy immunology specialists. There are less than 77 training programs in this country. And out of those 77 training programs, there are only 3 that do research on mast cells. A lot of times, practitioners don't know how to order the tests, and then when they do order the test, they'll say it's a normal tryptase. That is not the case. Please get a baseline tryptase, and then if you have an acute exacerbation, you should have a script so that the tryptase is checked. If it goes up 2 points, that is diagnostic for mast cell activation syndrome. And then lastly, some of the medications don't work. So Benadryl and Zantac and Zyrtec might not work. And that might be because for 2 different reasons. One, depending on what receptor is being engaged, if your mast cells are actually trying to fight off something, do you really want to restrain them with Zyrtec and Zantac? And then also, just to give you an idea, this is a patient that I had been taking care of about 8 years ago. She came to me for chronic hives. I ended up getting an electronic medical record and found out that she was getting prednisone and antibiotics from other doctors for the past 10 years. This is some of her lab work. I wanted to point out that her serum IgE level was 9. It's unusual to find people that have IgE recognizing airbornes, but she was recognizing mold and dust mites. And also her complement was turning over. That's another tissue inflammatory marker. So something's going on in the tissue that wasn't picked up by the CBC because you can see her white blood cell counts are within normal range. I actually, if anybody's come through my practice, you've seen the book that I give out as an intake questionnaire. It's about 19 pages long. She filled out that questionnaire. She was getting 5 to 6 courses of antibiotics every year for the past 6 or 7 years. So she actually had a primary immune deficiency. So she had common variable immune deficiency. And it was missed because everybody was staying in their corner of the sandbox. And she also had, in the setting of ongoing inflammation, where components from her cells were being released, she made an antibody against her own mast cells. So her mast cells were being tickled because she had a primary immune deficiency, she had a duplication of the tryptase gene, and she has an autoimmune mast cell disorder. Lots of things were causing her mast cells to release chemicals depending on how it was tickled, and her chronic urticaria, along with her mood disorder, got better when she got on IVIG. Hives, bloating, and by the way, she was given lots of different antihistamines, and she still said, my life is heck all the time. And she only got better when she got on gamma globulin. So again, this is just reminding you that mast cells can be tickled by lots of different things. It's really important once you get the diagnosis of mast cell or mast cell-ish to try to figure out what's causing the mast cells to release chemicals. So whether or not you have an autoimmune disorder, whether or not you have an immune deficiency, whether or not you have a connective tissue disorder. And so the questionnaire that I have basically is screening you with your story is more informative than the physical exam. And as far as, and the patients that have come through my practice have known, we talk for 45 minutes before I take a look at you. So it's really important to kind of craft your story when you go to the practitioner and do an assessment of what you might be experiencing. So this is just to show you, we had, for the past 4 years, I finally had a moment and some help to try to figure out what was causing these individuals to have hypersensitivity reactions. This is a screening questionnaire looking for primary immune deficiency. We had patients coming in with hives, with IBS, and we found individuals that have mannose binding lectin deficiency, idiopathic CD4 lymphocytopenia, which you normally see in individuals that have HIV, and we looked for HIV, it was not to be found. Antibody deficiencies. So mast cells are part of a team. It's just a question of who's telling the mast cells to do what, which is more so mast cell disorders are secondary commonly. What does it take to kind of live with mast cell disorders? And you can do that. Understand that mast cells have a job to do, recognize danger and respond to danger the best you can. This is how you diagnose mast cell activation syndrome. Again, symptoms, do you get better with medications, and do you have test results to support that? And to feel and live better, really you gotta step up you have to step up, because the doctors don't have the ability to do so for numerous reasons. So screen yourself. Get the appropriate testing that was listed in this. And then you need to educate yourself about your triggers. You don't have to do this by yourself, but it's really important that you partner up with a healthcare practitioner near you. You're gonna need boots on the ground. So you can see us, but if I'm in New York and you're in Arizona, that ain't gonna work. So it's important to kind of have someone who can help you figure out which practitioner you should go, which gastroenterologist is going to do the right stains, what neurologist is going to do the evaluation, because not all neurologists look at peripheral neuropathies. When it comes to psychiatry, sometimes you might do better on the old-fashioned medications as opposed to the newfangled SSRIs or SNRIs. Once you get the diagnosis and the treatment, and these are some of the tests that I order, depending on what happens in your story. So we do an evaluation for primary immune deficiency. We do allergy testing, including component testing. I do a screening panel for rheumatological disorders. We do allergy testing as well. And then there is a screen, and I'm going to retreat. I'll leave this to Dr. Francomano and all of her wonderful colleagues. But I do a Byton and Brighton, and then I'm like, okay, I know who you need to see. Once you decide that you have, once it's suspected that you have a mast cell or confirmed that you have a mast cell activation disorder, it's really important, it's really important to sort out whether or not this is a clonal mast cell disorder, meaning you have a mutation causing the mast cells to misbehave on their own. You have a duplication of one of the enzymes, the tryptase, but again, it's important to see whether or not you may have other disorders that are causing the mast cells to misbehave. Medications-wise, these are the various things that are available. So histamine blockers work up to a point. Understand that mast cells can kick out tumor necrosis factor, histamine, platelet activating factor. We actually took care of a patient about a decade ago who ended up having anaphylaxis to ibuprofen, and he went into disseminated intravascular coagulation. So he started to clot, then he started to bleed. Understand mast cells do kick out heparin. Matter of fact, the amount of heparin in mast cells is more than histamine. How do you treat? If they're allergens, avoidance measures, or the use of omalizumab, that antibody I was talking about, there's another one on the market right now called Dupixent, traditional Chinese herbal therapy, more the acupuncture and acupressure than some of the herbs up to this point. And then there are medications that target one of the cytokines that mast cells can kick out, called interleukin-5. You want to make sure that there's no autoimmune disorders, and this is where a collaboration with a rheumatologist who is open to treating non-serologic rheumatoid arthritis, for instance. And then also, you need collaboration for connective tissue disorders. Yay! Thank you for your attention.